Welcome to Variations 4, Musculoskeletal Units. Today we'll be covering questions 17 and 18. And that is primarily concerned with compartment syndrome. All right, so before we get into the maps talking about compartment syndrome per se, let's just take a step back and ask ourselves, what is compartment syndrome? And I'm going to put this question to you. What is compartment syndrome? And what are two mechanisms of compartment syndrome setting in? Let's take the example of a limb surgery, say a hip replacement, or even better, a broken leg, or you can take either one of those cases or both and come up with two ways that either one of those patients, or one way that one patient might experience compartment syndrome, and a second way for the other patient. While you're thinking about that, I really like this definition I found on the net here. I like the way they sum it up in terms of defining it. If you just want to read through that for a second. So we can really find two mechanisms of achieving compartment syndrome, if you will, from just reading this alone. If we look at a different picture here, so one way that we could get compartment syndrome is that within the muscle, there could be damage, there could be bleeding within the muscle fascia. These are different compartments of the muscle, and there could be bleeding within any one of them. Any excessive bleeding in any one will put pressure on surrounding vessels and surrounding nerves. There's one example of compartment syndrome. So to sum it up, an internal source, internal bleeding, internal swelling within the confines of the muscle fascia itself. That can basically happen with any limb that's experienced trauma. Okay, the second way is if you think of something on the outside of the leg, like a cast. If a cast is around this leg, and now the leg is experiencing serious edema or swelling, that's going to press against the cast and thereby press against nerves and blood vessels, and you've achieved the same problem, compartment syndrome. Here's normal muscle compartments. Here's swelling within those compartments or bleeding within those compartments. So there's compartment syndrome from the inside, and again from the outside. The second way would be a cast that's over top of a limb, that the limb itself is swelling up and pressing against the cast. We'll cut right to the chase. What do you do if it's this example, if it's swelling from the inside, and you've concluded that, okay, this patient has compartment syndrome, there is no cast in place here, what more can we do? Following our assessment and deductive reasoning, we'd have to get a hold of the surgeon's stat and get what's called a fasciotomy. And let's show you what that looks like. This picture here shows the fasciotomy of the lower extremity around the calf region. This is a really common place for a fasciotomy. We see it a lot. And you see patients with scars who've had a fasciotomy. They will actually leave this area open to decompress. That's literally what they're trying to do, is let it decompress. And then eventually they will put probably a vac dressing in there, something to pack it with to promote its healing. So this is obviously a wound that is healing by secondary or tertiary intention, where they've opened it up intentionally. Let's show you a picture of what the scar looks like, because this is something you'll see quite often, people who've had scars from fasciotomies. Here's kind of a before-after picture. You can see the real swelling there in the muscle fascia. And then they've had the, obviously, the fasciotomy. And then there you go with quite some time later. That's what the scar will look like. Pretty much for the rest of their life, they'll have that scar. You see that? I've seen quite a bit of that. But if we just come back to that, so we've talked about this one, the internal swelling, what you do if you figure out that it's compartment syndrome. First of all, the surgeon may just want to confirm the compartment syndrome is happening. They can stick a probe in to the muscle itself, and they can determine the pressure that is in that compartment, and they can figure out if it is indeed compartment syndrome or not. If the person has a cast on and you suspect compartment syndrome, you're going to want to, as a nurse, split that cast, take the cast off, and see if that solves the problem. It might solve the problem. It might have just been the cast and the pressure against the cast. However, the damage might already be done, and now you might already have caused swelling of the muscle, and then you're going to a fasciotomy. So with the cast, it's kind of a two-step process. Take the cast off first, right away, quickly, and then see if that solves the symptoms and signs. If it doesn't, then you might have to progress to this intervention of a fasciotomy in any case. So we just go back to our maps here now. Having said all that, let's look at a little more about what we assess and whatnot with it. So signs and symptoms of compartment syndrome, can you list them? You should come up with a good list here, 5 or 6 things. Here they are here. Here's the list of the symptoms. It says tingling right there. Pallor, paralysis, pulselessness. So my question to you is, does this patient have to present with all these symptoms to have and signs to have compartment syndrome? Do you have to find all of these, all 6 of these, the six symptoms here? Do you have to find them all in order to have compartment syndrome? The answer is no, you don't. You might find some of them. You might find only one of them. I've seen cases where the only symptom is the excruciating pain. That's characterized as excruciating pain, like beyond 10 out of 10. That is not helped at all by narcotics. The patient finds no relief. It's characterized as unrelenting pain that does not respond to narcotics. If you look at the patient's history, they've had limb surgery, and now they've got this unrelenting pain that narcotics are not helping with, you might want to suspect compartment syndrome and act quickly. So looking at the head-to-toe diagram, I think a lot of this stuff is pretty self-evident. I don't need to go into all that. The reason fat emboli is here is anyone who's had a fracture of extremities at risk for fat emboli. So this head-to-toe diagram on fractures, we've talked about one part, the compartment syndrome. There's another, and we've talked about some other things here that are pretty straightforward. This whole thing about myoglobin, can you explain the relationship between myoglobin, kidney function, and fractures? The explanation is this. Number one, whenever you have muscle damage, myoglobin is released into the bloodstream. So myoglobin levels will rise. Number two, these myoglobin get stuck or jammed up in the kidneys. This causes GFR to go down and possibly creatinine and urea to go up. You've got acute renal failure. How is this problem solved? That problem in and of itself is not too difficult to solve. Give them fast-running IV, perhaps an IV bolus if that's appropriate to flush out the kidneys, and you'll solve that problem. Most of the diagram looks pretty self-explanatory for fractures. very similar to what we talked about with hip joint surgeries, because those usually are um, fractures themselves, or same approach. So a lot of this is very repetitive from other diagrams we've looked at. A little note here on the use of ice. Check your facility protocol. It's typically something like 10 minutes on, 10 minutes off, and take a break, do it again, this type of thing. If you use too much ice early on for too long, it can actually cause a rebound inflammation. So careful with the ice, watch your protocols. A little note here on fat emboli, which we've talked about before, the importance of immobilization. We talked about just a quick little summary on how fat embolisms are managed in the ICU. It's basically supportive treatment. That's basically the overview of our fractures and compartment syndrome, and a reminder of some other points, kind of head to toe points when dealing with patients with fractures.